suction available, you're always going to have some suction available, so it is there for you. Because you will have a friend, they can hand it to you. So you're good. But what that would look like is if I'm right-handed, so I'm going to work with my right hand. So I'm just going to make sure that this is undone and ready and available for me wherever I need it. But if you forget it, you'll have another friend who you can say, hey, hand me the suction. Or you wait for them to give you the suction whenever you're ready for the suction. We do have little, this doesn't, this is just the collar that would go around the tracheostomy. But we don't actually have the tracheostomy port, or the intubation, if you will. So I am not going to put this in. You may just be working with an open hole. That's perfectly fine. Typically you also want to take the collar off and clean around the collar and clean then around the trach, which equally makes me want to vomit, but to each his own. Okay, patient in high Fowler's, we need to go a little higher. Assess nasal passages with your pen light, so you'll need your pen light again. You just want to make sure that they're patent. It says to assess the gag reflex by placing the tongue blade against the uvula. I mean, I guess you can do that. Like, why torture the patient any more than you're going to have to, because that thing's going to throw in the back of their throat. So you can verbalize that, whatever. Then it says to explain how a patient can communicate during the procedure, which I think that your ATI was sort of telling you, like, give them hand signals or something, because they're not really going to be able to do too much talking. But you can kind of give them a, like, stop or a, timeout or we're good or whatever. So you can just create your own communication. Speaking of, never mind. I watched this, like, Alien, so here I go. I am not a sci-fi kind of person, but my husband showed me The Arrival. Has anybody seen that with Amy, what's her face? We've got a nod back there. Anyway, great movie, but a lot of it's communicative based. Anyway, if you're feeling fancy, watch it. I'm not going to give you one. But communication comes in all forms. So, okay, measuring the tube for length. So, how do I measure the tube for length for insertion? What's the golden rule? Where do I start? Cool. All right. Just here? Is this long enough? Oh. Cool. Okay. I think I'm gonna go to the earlobe and then come down to the xiphoid process. So tip of the nair to the earlobe, xiphoid process, and then we'll see if we have a marker, but this is very sticky, right exactly where I needed it. Awfully convenient. So you can just kind of take note of it. If we have a marker, which I don't see one, then you'll mark it. If not, you can just verbalize, you would mark it. You're not going to be able to get it in 60 centimeters anyway. We might make it 10 because of the way that this is designed. So you'll just verbalize then that you mark it, or with a piece of tape. We'll see what I can get for you. Then you're going to cover the patient's chest with a towel, so you will have a towel. It's funny, we've actually not been able to use towels until today because of COVID, because COVID's in the fabric. COVID's in a lot of things. COVID is in lumber, obviously, as well. Okay, so then you're going to have them hold this emesis basin in a cup of water. So, again, this patient really can't do too much, so you could just drip it there. And they're going to have this cup of water. I'm not going to take the straw out, but you can have it there with a straw. Coat the tip of the tube with a water-based lubricant, which we have here. So you can put it, we'll find something. So the trays that we had, or used to have, had those like sterile cups, which this is not really a sterile procedure, but that's where we were putting the lube. But we don't have that. So you can put it in another cup, or you can just verbalize that you would do it. Or you can just say, I would put, squirt it on. Because this hasn't been used at this point. And this is still clean and good. So until it touches the patient, you can technically do that. That's probably a big no-no, but like it's clean. Anyway, so then slowly insert the tube into the nair. So I would start then here What am I going to tell the patient to do while I'm advancing the catheter? Chin to chest, swallow. So they're going to have their cup of water, sipping on this, and every time they swallow, you're going to advance. Why am I doing that? It closes the epiglottis and it helps advance that catheter on down. So yes, co-tip slowly insert in the ears. Instruct the patient to touch chin to chest. Advance tube each time the patient swallows until reaching the marked spot. So swallow, advance, swallow, advance. Wow, this is not going anywhere. Cool. Maybe I can get it the other ear. Aha! Nope. All right. 10 centimeters. That's all you get. So then you're going to use that pen light. Oh, sorry. So you would then just verbalize if there's any resistance, significant coughing, gagging, choking, changes in vital signs. Then you're going to pull back on that tube until it is resolved. Why would I do that? Why am I going to pull back on the tube? What's my suspicion? Trachea? Is that what I heard? Yes. Yeah, I'm going in the lungs. Exactly. So I want to make sure that I get out of the trachea and into the esophagus. Use the pen light, the back of the throat. Auscultate for breath sounds. So I think your ATI said that this is actually not a recommended practice anymore. No, it's x-rays that aren't recommended practice. Used to, we did all of it. But for some reason, I'm thinking ATI said that one of them was not recommended. But until there's confirmation, we do both. So why am I listening to breath sounds? Yeah, because essentially what we might be doing is inflating this with air, and that's getting into the lungs. The other thing you can do is listen to in the stomach, like literally listen sort of where that stomach would be, and insert some air and see what happens. Because you might, if you hear the air in the stomach, then you're like, oh, breath sounds in the stomach, odd, but you want it there. So these are all different ways to confirm. Most of the time what they're going to do is an x-ray to confirm that that is in the catheter's in the right spot. You're not in the trachea or in the lungs. So then you're going to use a syringe, withdraw gastric contents, assess the aspirate, and test the pH. So we don't have the pH strips today, but hopefully we'll have them there for you for your exam. So this is not the right thing that I need, but that's okay. Oh, that's unfortunate. Whatever you can get to connect it to. I don't know that this would totally work in the real world, but you're just going to pull up, gather gastric content, which you're not actually going to get, so it's just pulling up from a syringe. Pull up that way. You're not going to get anything, obviously, because we're only 10 centimeters in, first of all, and secondly, he doesn't have any gastric content. But then you'll just squirt it into an emesis basin, or squirt it, the invisible it, or into a cup. And then we'll have little pH strips for you, I hope. I didn't think, I'll double check in there, but I don't think there are any. And then you would check the pH to make sure that it is gastric aspirate. What pH does it need to be below to technically be gastric aspirate? 5, yeah. So what is the pH of the stomach normally? Roundabouts. It's technically 2. It's very acidic. Hydrochloric acid, it's got to break down that, break down all of the food. So it's typically very acidic. But if you're, and it's more acidic with food in there, right? Because the body's gearing up, right? It's why people have issues with ulcers after they eat. It's because once the food hits the stomach, then the excess acid that is produced aggravates the ulcer even more. So then you're going to anchor the tube to the nose, again taking that piece of tape sort of coming underneath, and then, does that make sense? Cool, okay. I know you saw it on ATI yesterday, so I'm like, and then mark the tube so that you can see if there's any migration. Fasten it to the gown. We won't have a fasten, so don't worry about that. And then just make sure to keep the head of the bed above 30 degrees, which there's a fancy little whatever this thing is called, leveler on the side of your on the side of the bed that shows you exactly what degree the head of the bed is. So you'll leave it there. Okay, so then gastric decompression, you're checking the NG tube placement, check. Placing the towel, check. Verify the suction that is working. The suction actually doesn't work, so you can just verbalize that you're gonna note that the suction is working. And then, oops, sorry, sir. Then you will connect the NG tube to the suction via the adapter. So you will just slide this guy. Well, I'm actually gonna take this and put it here. So you'll, good grief. I think I need an adapter. I'm gonna stick it here for now, but I think that there might be another tool in there that connects these two together, because that's ridiculous if that's how it works. So connect it, and then you're done with that. So I'm gonna see if we have that piece. Any questions?